Welcome, guys, to our fourth iteration of the military medical community. It's our first Monday of the month. We're highlighting emergency medicine tonight. We have four excellent speakers tonight, and we'll take the next slide. Big shout out to uh, all of our partners that we're working with from the ERMA Government Services. You're going to hear more from our kind of keynote about the GSACEP, and then the USAAEM. As well as our Army, Navy, and Air Force HPSP recruiter teams. You'll have the chance in the breakout rooms afterwards if you're interested in USU or you're interested in HPSP and going to another school. Please stop in and talk to one of the physician recruiters in the Army, Navy, Air Force. Don't feel like you need to stay in one room. You can bounce around, get your questions answered everywhere. And if you loved hearing the stories that you're going to catch tonight from our speakers, check out War Docs, and there are a ton of other content that you can see there about what other people's careers in the military and what you can learn from military medicine. Next slide. Big shout out to Jasmine De Jesus. She's out of UT San Antonio, and she has started her own local MMC chapter. The bylaws are on the website, so if you go to USUHS and then the MMC, you can find bylaws that you can use to easily make your own chapter locally. We provide all the content. It just gives you an opportunity to meet, network, create your own local group. And she pulled together a group where they did some kind of Halloween tour, as well as they had a guest speaker and learn more about Penn State. Anyway, we can also help you find a local mentor that can hopefully help you reach out and learn more about military medicine, maybe even find shadowing and other networking opportunities. So again, thanks to Jasmine. Next slide. And then before we get here, we'll go back one slide. Samuel Lanuti, we didn't pull up a slide for him, but he's out of University of Arkansas and he's doing basically the same thing. He's started his own chapter there in Arkansas, Fayetteville. So we'd love to have more involvement. Grab the website or reach out to us and we're happy to help you go with that. And then I'm going to turn over. I'm just a lowly dermatologist and pediatrician. So I've tagged Ryan Leone, who is one of our fourth-year HPSP students out of Columbia, to help us moderate tonight. So, Ryan, please quickly introduce yourself, and then I'll let you take over, my friend. Thanks, everyone, for coming.
Thank you so much, sir. Really appreciate it. Hey, everyone. As Colonel Cox mentioned, I'm Ryan. I'm a fourth-year HPSP student at Columbia. Previously spent some time working for the Defense Health Agency in the State Department before going to medical school. And I'll be in the rooms later on for breakouts if anyone has questions for a current med student that's also navigating the residency process. And conveniently, I am a wannabe emergency medicine resident. So it is a great time to be here as a part of this event while I hopefully find out my fate in December. And I'm honored to be introducing you to some really, really amazing speakers we have this evening representing the three services and three different stages of their careers, those who are early career, those who are, early attendings, those who are now in program director roles, and those who have retired from the military and are continuing to serve in various different ways. The first of these illustrious speakers that we have for you is Lieutenant Erin Snyder, who is a fourth-year emergency medicine resident at Naval Medical Center San Diego, where she does research with the Combat Trauma Research Group West. And I will turn it over to her to share more about her awesome background.
Hi, guys. Thanks for having me. So I guess good afternoon to the people on the West Coast and good evening to the people on the East Coast. So I was asked to kind of present on kind of residency and a little bit of pre-residency. I don't want to bore you guys with a bunch of words. There's going to be a lot of pictures. And so I'm going to try to get through this and then leave it open for questions. And then I'll put my personal email and my cell phone number in the chat. So if anybody wants to reach out with questions, I'm also the current residency clerkship coordinator for medical students. So if you have any specific questions about that, I'm happy to answer any questions. So with that, we'll go to the next slide. So I am from Kentucky. So born and raised, I ended up going to undergrad at a kind of smaller school in Kentucky called Transylvania University. Our mascot at the time was not the bat, but it was changed after I graduated to be the bat. So it actually means into the woods in German. So I was able to play soccer and softball there. I participated in a sorority and did pre-med. So during my time in undergrad, I also participated in some research that kind of helped me get my foot in the door with research. At that time, I saw it as kind of a requirement for applying to medical school. I was not somebody who was like super gung-ho about doing research. So this is kind of where my research background kind of started. But I definitely didn't see my future going in that direction. And then this is my dog, Duke. He was a staple during undergrad. And so if you go to the next slide. So I graduated in 2017. I took a gap year. I was a surgical nursing assistant at a local hospital. With playing college athletics, I didn't want to stress myself out by trying to get all of the prereqs and MCAT in. So I took that my 4th year, took a gap year, and then went to the University of Kentucky for medical school. And so my uncle was a physician that went to the University of Kentucky. So he gave me my white coat. And so starting in, I want to say my transition from 2nd year to 3rd year clinicals was when COVID happened. And so we get kind of bumped out of the clinical space. And so that was a very stressful time for me. I got really into turkey hunting during that time because we weren't allowed in the clinical space. So I was doing UWorld questions in the blind. And so then I graduated in 2022. I had matched to Naval Medical Center San Diego. And so I was finishing up my time at the University of Kentucky. While I was there, I helped out with a couple orthopedic surgery, specifically trauma projects. And so again, saw it more as a requirement, but I did enjoy trauma. I'd initially thought about maybe going into orthopedics and then got really into emergency medicine, and some of the best research in terms of trauma at the UK was being done with the trauma surgeons. So kind of got involved in that. And then going to the next slide. So during your time during medical school, if you do the HPSP program, you'll be going to ODS, which is the Officer Development School in Newport. And so I know with COVID, again, it has kind of messed up the timing, but ideally you go from your 1st to 2nd year during that summer, but it's kind of all like, messed up. So even if you haven't gone to ODS yet and you're like, rotating through even Balboa or Portsmouth, no one expects you to at this point with everything that's been kind of backloaded. But it was a great time, had a lot of fun, met some really great people. I'm actually one of the providers, and the picture on the ship right in the middle, he's a OMFS surgeon at Balboa. And so I've run into him a decent amount. And so it's super small Navy. It's really good time. Kind of introduces you to wearing your uniform and how the military kind of works. And so that timeline, ideally they want you to go before you graduate, but we have people now that have gone into the residency that have not gone to ODS yet. So it's something that's a great opportunity. Definitely try to go, and definitely helps you prepare, but I wouldn't lose a ton of sleep if you can't get it in. And so next slide. And so my audition rotation, so the most important date for you guys to remember is December 1st. So that's when rotations open for HPSP. And so I remember setting my timer for midnight and to wake up so that way I could put my application in. And that's kind of the way that it's been done, is first come, first serve. There's been some discussion about trying to make sure that we get the highest quality medical students to be able to rotate with us, because it is so competitive. We unfortunately had a really large wait list. And so we even created an ultrasound course to try to get people in, just to get some exposure, just to get some faculty interaction. But this is going to be the most important date of making sure you guys know this one, of December 1st, of putting that down. Your rotations are going to be usually May to September. And then making sure that all your material has been uploaded to MODS, generally by the 1st or 2nd week of October. I auditioned in the first block of my 4th year. And so I was early, so MODS hadn't opened. So I just printed it and gave it to the rotation, and that worked out fine for me. It was also really nice because it wasn't super competitive. Unfortunately, due to COVID, Balboa was a red site still from not being able to get funded. So they had offered, if you want to pay for it, if you really want to go there, you can pay for it. And so I ended up doing a cross-country road trip. And so the pictures that you see are all from this cross-country road trip. And so The bottom is Colorado National Monument. There was a canyon that I stopped at. There's Las Vegas. While I was out here, I did a hike up to John Muir and then the Five Lakes, and then the classic sailor kissing the nurse in San Diego with the beautiful San Diego city in the background. I also hit up Watkins, which is super easy to do. It's right outside of an Air Force base. So I just stayed there and got up early in the morning and went, and then driving past the Arc. And so making sure that you have those dates down. And again, you can reach out to us. It's all on Joel Schofer's blog as well. And it should be on the website as well. And so next slide. And so then Match Day, super exciting. I think it's a lot more fun for HPSB students because we already know. So have your match party with your colleagues. They match much later, right? So we find out in December. They don't find out for another 2 months, I want to say. So I had matched and got to celebrate with my family. So then I went to Match Day with my colleagues, and it was much less stressful. I already knew where I was going. And so matched and had my Naval Medical Center San Diego sign and got to put my little pin of where I was going. And so that was really exciting. And so Match Day will be a really exciting time for you guys. And it can be stressful, but, the match kind of works for you. So everybody kind of ends up where they're supposed to go. And then the next slide. And so this one is a little chaotic because residency is a little chaotic. And so I want to talk about residency, resiliency, and burnout. And so I think, if you haven't burnt out in medical school, you're going to burn out. And so the biggest thing that I've talked to the medical students that rotate with us and interview with us is about finding the things that fill your cup back up and making sure that you make time for those during residency. And so I really value interacting with people. Emergency medicine, we're all usually pretty athletic and outdoorsy people. So making sure that you are able to find time to do those things, hanging out with your colleagues. Residency, yes, is kind of like a job, but these are the people that are through your life for the next 4 years. And so some of these are my best friends. They've gotten me through, my dog passing away. They've gotten me through, anniversaries of family members passing away. They've been there after difficult pediatric trauma cases. They've been the people that you kind of vent to, laugh with, spend time with. So making sure that when you do get down to finding your place where you're going to match, making sure that the culture is solid. And these are people that you can definitely see yourself working with. There's not a single person in my residency that I wouldn't want to deploy with. I think in the civilian community that can vary. We're all very team-oriented people. Emergency medicine attracts usually people who have participated in team sports, team players. And especially in the military, it definitely promotes that team mentality. And that's how emergency medicine works. All the way from, custodial staff to the department head. Everybody has to pitch in. And emergency medicine, you never know what's going to walk in the door. So everybody has to be pretty squared away. And so making sure that you find the time to kind of decompress. So hiking with my dogs, going surfing. I've picked up quail hunting out here. I'm a pretty avid runner, so making sure I make time for running and races, all of that is, something that's really important, and making sure that you really find those ways to refill your cup because, it seems like in medical school, it's a negative to take time to work out and not be studying. It's going to end up hurting you later. So that would be my biggest pearl of, making sure if it's, painting or reading or just hanging out with friends, making that time because it's a slog, 4 years of medical school, 4 years of residency, and you're going to need support. So making sure you find the things that fill your cup back up. Let's see, next slide, please. And so research. So I believe I was asked to do this particularly from my research experience. And so I got really involved with the Combat Trauma Research Program. It was one of the reasons why I wanted to come to Naval Medical Center San Diego. They have the West, Portsmouth has East. I really, clicked with Captain John Otten when he was the program director here, who has a very solid research background. And so when I came in, I didn't think that I was going to do as much research as I did. But I've been afforded amazing opportunities of being able to present at AMSIS, being able to present with MHSRS. I've gone to Special Operations Medical Association twice and presented there. And, I was the 39th annual Balboa and Navy-wide research competition winner. And so if you had asked me in medical school if what got me out of bed was research, I would say no. But it is kind of something to be said of don't go into it assuming you're going to hate it. I joined the military because I believe in the mission. I believe in, doing things towards preserving the life of the wounded warfighter. And that's exactly what the type of research that I'm invested in. So right now, I've got a publication pending with JSOM with my SimIO study, and then we're working on trying to find out a way to standardize the walking blood bank, filling those blood bags. And so I included the last picture on the bottom right corner because I presented via Zoom for the Navy-wide competition, and then I had to go to the airport 30 minutes after I finished because I was on the East Coast at SOMA in Raleigh. And so I was dressed for the airport from the waist down, and then I had my uniform on. So I just peeled it off and then hightailed it to the airport. But yeah, you get to meet really great people through research. And so if you're interested in research, definitely pursue that and find ways to make it happen. Next slide, please. And so again, this is why we've all, considered joining the military, is our military unique curriculum and preserving the life of the wounded warfighter. And so these pictures are amalgam of me running lanes with NSW medics over on the Silver Strand. I help out teaching ultrasound courses and running their prolonged casualty care course in some of the trauma lanes. And then some of them are from C4. So C4 is was a graduation requirement for residencies all across the board. And then there's some funding issues. And so they're kind of working with that. But, I came together with, pediatric residents, IM residents. And so we're running trauma lanes together. And so that was really fun. I felt really prepared being an EM resident, especially with an interest in TCCC and combat medicine. If you're really interested in military unique curriculum, there's ways that you can help pay things forward and really contribute to making things better. And so I had donated probably hundreds of hours at this point of teaching the ultrasound course and running the PCC lanes. I also mentored some of the medics to help them get into medical school and their application process. And so I was really honored when they recognized me with a NAM. And so that's the center picture with the faces blurred out is me receiving my NAM from them, which was a huge honor, and I did not expect it. But just goes to show that the things that you do really can have an impact, even when you're, just a resident. I think everybody thinks, oh, you're just a resident, but what you do can really make an impact. And so would you mind doing the next slide? And so the biggest thing would be find your why and remember your why. So going back into filling your cup. And so, I've always been drawn to being in the service of other people. And so one of the favorite Bible verses I've ever seen is, John 15:13, which is greater love has no one than this, to lay down one's life for one's friend. And so, again, we all join the military for different reasons, but being able to potentially reduce somebody's suffering or save somebody's life is huge. I grew up watching my cousin, John Paul. He flew for the Blue Angels during 2013 and to 2015. And so that also really inspired me. And then my grandpa was a corpsman during World War II. And he actually trained at Naval Medical Center San Diego when it was the pink building still. So that was really cool. After I had matched, my grandma's basement flooded, and we found a box of his old letters, and they were on the stationery of Naval Medical Center San Diego. Everybody has their own reasons why, and then you click next. Even if it's a Delta Force guy telling you that this is his safety. So Black Hawk Down was a huge movie for me of really wanting me to get into the fight. And so Even if you just want to run and gun with the cool guys, everybody has their own reasons. So find your why and really hone in on it. So with that, I'll take any questions anybody has.
Thank you so much, Lieutenant Snyder. That was really, really great. You definitely show that there's much more to residency than just taking shifts. So thank you for that. We're going to save questions until the end when we go to the breakout rooms. And I will turn it over to Lieutenant Katie Clark, who is a recent graduate of Harvard's Emergency Medicine Residency Program, and I believe now a current attending at Walter Reed, to share more about her career and insights. Over to you, Lieutenant Clark.
Yes, thank you so much for having me. It's a real honor to get to speak to everyone tonight. Everything that Dr. Snyder just said resonated a lot with me as well. I recently graduated from residency, so it's so great to hear her story too. I wanted to start sharing my career path timeline, and hopefully this will be helpful for those who are in any stage of their medical training. So I attended Duke University. I had a major in evolutionary ecology, and I graduated in 2014. I took 3 gap years. When I first went to college, I thought I was going to study economics and go into banking, and that thankfully quickly changed. But I felt like I needed time to kind of figure out my path and do a lot of the other pre-medical kind of prerequisites outside of college. So I worked at the National Cancer Institute at the NIH, working in a tumor immunology lab. And that's where I think, fell in love with parts of research, and that kind of continued throughout my career timeline as well. After those 3 years, I attended Johns Hopkins University School of Medicine up in Baltimore, so not too far from where I've been living in the DC area. And I was there for 4 years. The summer after my first year of medical school, I similarly went to Officer Development School in Newport, Rhode Island. It was great to kind of get some exposure to military medicine early. I think now, having done a civilian residency program and going on active duty this year, I realized that 8-year gap from ODS till now, it might have been a little bit more useful in a more proximal location to graduating residency. But every student, for the most part, or resident will attend ODS at some point, hopefully prior to starting on their active duty service. And then during my 4th year of medical school, and I'll speak briefly to this as well, I applied to both military and civilian residencies and matched into a civilian residency program and attended the Harvard affiliated emergency medicine residency for 4 years up in Boston. I graduated just this past July. PCS is my first command at Walter Reed, which is back right across the street from the NIH. So it's kind of surreal to be full circle and kind of be back to where I started at the beginning of my medical school journey. And then I kind of hit the ground running. It's been a steep learning curve, I think, coming from fully civilian training to now military medicine. But I've had the privilege of working so far with a lot of great people who have been very supportive in helping make that transition easier. Next slide. So here are just some tips to be on the lookout for applying to military residency. If you're interested in eventually kind of going the civilian route like I did, you'll want to be on the lookout for the BMed note, which every year will say how many training spots there are at the military training programs in Fort Smith and San Diego. And then they'll also say, as you can see here under the red box highlighted for EM, that if this year, whether or not they'll have NADS opportunities. And that's essentially your pathway into applying to civilian residency. If they're offering NADS opportunities in emergency medicine, that means that you can apply to civilian residency programs. It's not always clear how many students they allow to go that route, and it really kind of depends on the needs of the Navy as well as their projected needs. Emergency medicine, along with a few other specialties such as surgery, orthopedics, psychiatry, anesthesia, are all kind of tip of the spear specialties, meaning that we're very deployable and we're ready for the fight. And so looking down the line, at least the year that I was applying to residency, they projected a greater need for emergency medicine physicians and kind of outsource some of that training to the civilian population. The dates for applying to military residency, as Dr. Snyder mentioned, is a little bit earlier than applying to civilian residency programs. I applied during COVID, so I actually learned that I was matched into civilian residency or had the opportunity to match into civilian residency in January, but usually that military match occurs in December. And if you're interested in making civilian residency your first choice, then when you apply through the military route, you'll actually preference civilian deferred or NADS, as you see highlighted in the bottom red box, as your first choice, and then place your other options for training within the medical system below that. And then if they offer you your first choice, you would match into NADS. Next slide. So concurrently to applying to military residency, you'll also be applying to civilian residency. The year that I applied, we used the ERAS system. It seems like now it's changed towards residency pass, which I'm not quite as familiar with. But I think they are trying to garner, at least cater more to the medical student during residency application. They let you preference your geographic preferences, explain more about who you are as a person with the hobby section, and added some other kind of categories to fill out. And then the key dates are listed below for applying to civilian EM residency. There is a kind of a unique point when you're applying to civilian programs. You'll be interviewing at civilian residencies, and program directors might ask you whether or not you're planning on attending a military program or a civilian residency. I found, at least in my case, that just being honest and genuine and saying where you are in the process, for me, especially because I didn't match until NADS until January, I just explained what my circumstances were. And it seemed, at least, that most civilian residency program directors were very receptive to that. Next slide. I want to reiterate, too, the importance of sub-Is and away rotations. My year as a MS3, MS4, I unfortunately wasn't able to do any sub-I either at civilian or medical residencies. And this was because COVID had largely shut down those away rotations and those opportunities. Now being on the other side of residency and also being a deputy site director at Walter Reed, I see very much the importance of sub-Is. And I think it's a great way to showcase your skills for whatever programs that you're interested in, as well as for you to get a chance to interview the programs back and see if they're going to be a good fit. I can't emphasize more what Dr. Snyder mentioned about those 4 years of residency are very demanding, and the colleagues and the co-residents that you found yourself are going to be your family, your support system. And I really would encourage you to feel empowered to choose programs that you feel like are going to be a good fit for you as well. I will say that some residency programs also offer interviews to all the sub-Is that they have rotate with them. And so it's a good way to get your foot in the door for that first interview. Next slide, please. Just to talk a little bit about my civilian residency program, which is a little bit different than the military residencies, which have a really cool and unique military curriculum. I chose to train at a large urban center. So the Harvard affiliated programs are affiliated with MGH, Mass General Hospital, and BWH, Brigham and Women's Hospital. And in part, I felt like going to a civilian program to these large urban centers, I could see some of the things I was most interested in, which is like a large amount of sick patients, high volume, high acuity, and trauma patients. So MGH is the largest teaching hospital of Harvard Medical School. It sees over 100,000 ED visits each year, which is a very large number. It's a level 1 trauma center, both for adult and pediatric patients, as well as a regional burn center. And it has a very high acuity, at least relative to the hospitals kind of in the surrounding system. And about 10% of the ED patients that we saw required some sort of critical level of care, and usually resulted in ICU admissions. One part of the MGH's emergency department, called acute, is actually only see like ESI 1s and 2s. And as a result, you're basically running a mini ICU when you're working in that part of the department. Brigham and Women's Hospital is also a relatively large urban academic center, seeing about 60,000 patients each year. It's a level 1 trauma center. It's also a regional burn center. It has multiple subspecialties, so it's a tertiary care facility for the surrounding community. And then one thing that drew me to it in particular is that is affiliated with Dana-Farber Cancer Institute. And so I had a particular interest in oncologic-related emergencies, given my background working at the National Cancer Institute. And I found that working with those patients and as a resident was very meaningful for me in particular. Next slide, please. I think that one of the benefits of choosing a 4-year emergency medicine program, and granted, it seems to be that most programs are going to be moving that way in the near future. But at least for me, it was the amount of extra time we had built into our schedule to pursue different clinical electives. Sometimes that electives can include ultrasound training, research, and for me in particular, I was interested in wilderness medicine and medicine in limited resource environments, in part because I felt like the community aspect of medicine was lacking somewhat in our large academic centers. And then secondarily, I wanted to make sure I was able to have the skills that would be more transferable maybe to deployment or military settings. So during my PGY2 year, I was able to rotate at Fort Defiance, which is one of the rural hospitals in New Mexico on the border of Arizona, 8 miles from Window Rock, Arizona, which is the part of Navajo Nation hospital. And so it was a really unique patient population that you got to see. You also got to deal with things that heavily afflict reservations, such as access to food, addiction medicine, and alcohol-related illnesses. There's also unique epidemiological viruses in that part of the Southwest geography, including like hantavirus and things I wouldn't necessarily see in Boston Metro Center. Next slide, please. I also spent time at Catalina Island Medical Center, which is one of the Channel Islands off of the coast of LA and San Diego. It's a really cool medical center because it's a freestanding emergency department. It caters to the year-long island residents, as well as the almost 1 million tourists that come largely via cruises and cruise tourism throughout the summer months, which heavily increases the number of people on the island, as well as the number of illnesses that come with that. What's unique too about Catalina Island Medical Center is that it has on the southern part of the island a freestanding hyperbaric chamber, one of the oldest in the country, and it's run primarily by physicians at UC San Diego. And while I was working at Catalina Island Medical Center, I was able to see a large number of dive-related emergencies. Again, skills I thought would be transferable potentially to military medicine, and also part of my own interest as a dive enthusiast. Next slide, please. And then kind of bringing those two types of resource-limited environments together, I was able to work at Martha's Vineyard Hospital, which is a hospital now affiliated with the Harvard Medical System. It's, of course, off the coast of the Deep. It's about an hour ferry ride on the fast ferries that happen throughout the summer months. And then something that I was never aware of is that during the off-season, shoulder season, winter months, there's a large Portuguese-speaking population that lives there year-round that largely conducts a lot of the construction and service-related industries. And so I saw some unique construction-related accidents, needing to decide whether we admit to the very small hospital on the island or we have to transfer to the coast for trauma surgery or other subspecialists. Again, interesting too, because you have the ferries that can go at certain times of day, but at night or in bad weather, you have to decide whether to keep the patient, try and stabilize them on the island, or transfer via helicopter. Always kind of a difficult decision to make, and certainly one that is applicable again to military medicine. Next slide, please. Given kind of my interest in wellness medicine and dive medicine and some of the clinical experiences I had, we were actually able to establish our own unique dive medicine curriculum. And we were able to go diving too as part of that. So this is us on the North Shore in Gloucester, kind of off the coast, diving in the cold Atlantic, where it gets down to about 45 degrees. You get to see lots of cool marine life, including lobsters and scallops and clams. And then we were also able to talk about a lot of dive-related injuries, including arterial gas embolism, decompression illness, and just learn from people who love to go diving themselves. Next slide. Putting this together, I think I had the privilege of working with clinicians that were also very interested in research. And I think that's one way in which you can give back to the field of medicine and at least advance clinical care is through research. And so for me, again, it was an interest in resource-limited environments, wilderness medicine, and space medicine. And actually, my program established one of two space medicine fellowships that are open to emergency medicine physicians. And so I was able to work with kind of at the intersection of ultrasound research and space medicine research. And we came up with a unique curriculum, at least advertising what should be taught to the astronauts as well as the crew members on long space flight missions, where you won't have access to other types of diagnostic imaging like X-rays or CT scans in the event of a medical emergency. Similarly, we looked at commercial airlines and found that a lot of their emergency medical kits, their recommendations had not been updated in decades and lacked basic things like blood pressure cuffs or epinephrine pins. So we were able to at least give some recommendations for updates to those EMKs. And then finally, coming out of the COVID era, which is my third and fourth year of medical school were largely the height of COVID. And then as an intern, it was kind of after the vaccine had become available, but we were still seeing a lot of COVID-related sickness as well as barriers to care in the setting of COVID. And so we looked at the feasibility of whether patients could self-scan and whether those images could be not only interpretable, but acted on by remote radiologists or clinicians to help care for COVID patients that maybe were not able to be seen by a physician at the bedside at the time. Next slide. So I think one of the benefits of going to the civilian residency program that I did go to is that I was just surrounded by amazing people, amazing colleagues, both the faculty, the fellowship training physicians, and then my co-residents who now graduating just a couple of months ago have all gone on to do pretty amazing things. And I'm lucky that I feel like I get to continue to learn from them and stories. And hopefully I'm able to at least take some of my own experiences from the civilian world and bring them to military medicine. Next slide. And I PCSed in July. I took a while to get credentialed, but I started working my first attending shifts in September. And then in October, I went on A-11 deployment training, combat training for a deployment to Baghdad, Iraq. This year is in Fort Bliss and Camp McGregor. And because our deployment would be supporting an Army base in Baghdad, we were taught by the Army in terms of the operations, radio communication, and then we also qualified on the rifle and the pistol. And so I feel like I got to kind of hit the ground running and getting caught up to speed in some aspects of rifle medicine that maybe was more limited for me coming from the civilian side. And in late October, I returned back to working at Walter Reed, and I've also been able to step up and take on new positions as the deputy site director for interns and rotating medical students at the Walter Reed Emergency Department. I've also been able to help as like the trauma liaison as we start moving towards trauma credentialing at Walter Reed as well. Next slide. And so if I can hopefully provide some pearls that will be helpful for those that are looking forward to applying into emergency medicine, talking with my program director and the chair of education from my residency, I asked him what he looks for in students that are applying to EM. And he wanted to emphasize leadership as one of the most important qualities. I think students coming from a military background or military medical school already have a lot of experience in leadership and kind of are at a great advantage there. But you're not only looking for leadership in the military side, they're also looking for leadership at the bedside and in clinical medicine, including being the leader in a room, running resuscitations, medical and trauma resuscitations, and being the person that is able to keep that team together. Similarly, we're looking for clinical excellence, and I would just encourage each medical student to keep working on their clinical acumen and kind of learning and seeing patients and learning from every patient that you do see. We also, especially emergency medicine, which often is the safety net for uninsured patients, programs I think are looking for service and the act of being able to give back to others. For me, I think it was really important to work with vulnerable patient populations in an urban environment, especially undomiciled patients. But whatever service means to you, I think program directors are eager to see how you have given back to others in some way. And then also academic potential, and that could include research if that's something that's of interest to you. And I just want to say thank you so much for the opportunity to speak with you all, and I'm happy to stick around for questions in the breakout rooms as well.
Thank you so much, Lieutenant Clark. That was really, really great. Appreciate you talking about your civilian experience and that transition from civilian to military, as well as some details on the match process that everyone has to look forward to. With that, we'll now move on to talking to someone who is a bit later in their careers and attending. We have Lieutenant Colonel Mike April, who is the program director of the Sawcheck Emergency Medicine Residency Program at Brooke Army Medical Center. He is going to speak to us about his career and about the program then at BAMC from the Army perspective. Colonel April, I'll turn it over to you. Thank you.
Thanks, Ryan. I appreciate the opportunity to speak to everyone. Before I get too far into it, I do just want to foot stomp 2 points that Dr. Clark made. First, she gives some great information about civilian residencies, the match, et cetera. Some of that's a bit Navy specific. I'd encourage you at the end of this presentation, there's a contact info where you can email us, call us, and we'd be happy to give the Air Force and Army folks some oversight on what that looks like from their lens. The other piece, she spoke about advocating transparency with program directors during the match. And I can't possibly overstate that. We truly all do really want you in places that are going to be good fits for you. Sure, me as a program director, I want all the best candidates coming to us. But at the end of the day, people are going to achieve their full potential, which is really why most of us are in this business, if they are in places that are good fits for them, good fits for their family. So I would encourage you, to the extent that you're comfortable and willing, to just be very forthright with everyone as you're going through interviews about what your goals are. With that, I start most of my talks with this slide. Of course, this is not from my story per se. This, of course, is June 6, 1944, as Allied forces are storming the beaches at Normandy. But I like starting here. Dr. Schneider talked about the importance of connecting with your why. This really is my why and my program's why, and I think connects a lot of what brings many of you to this room in the first place. It distills in a single picture what we're all about. I spend a lot of time looking at this, trying to put myself in the headspace of what these soldiers were experiencing in this moment. And it is a very scary, violent business, human warfare. But you all have volunteered by virtue of your military affiliation now to stand astride both the profession of arms and medicine. And you are who's going to be standing there to catch them when they fall. And I cannot possibly overstate how inspired I am by that, and also grateful I am for it. So thank you for doing what you do. But I became very enamored with this photograph, the study of World War II, in high school, and it really drove me to become very interested in a career in military service, frankly, before any interest in medicine. Next slide, please. This grainy photograph is my first day in uniform. You can't really pick me out amidst those goofy looking individuals in the white shirts, but I am back there wearing some preposterous glasses that I've just been issued by the United States Army. But this is reception day, the first day when cadets show up to West Point and get their initial indoctrination into what it is to be a cadet and a soldier. So, of course, just a couple months later, 9/11 occurred, and took what was already a very intense bonding experience and rapidly accelerated it, as it became very clear to me, my classmates, and those who were graduating in the classes ahead of us, that we were not going to be entering a peacetime army. We were going to be entering military service during a far more dynamic period. But these 4 years were very formative for me. These are my sisters and brothers in arms, and what I love most about my alma mater, and still love about it, is the absolute dedication each individual has to the success of those to their left and right, the faculty to the success of the students, because everybody recognizes in this institution, and I'm sure the Air Force Academy and the Naval Academy are no different, that they all are going to be entering a life or death business. And your life may well be determined by the abilities and the prowess of those that are graduating. So I truly believe that these 4 years helped me achieve my full potential. And I'm incredibly grateful for that. Next slide, please. This is me on the tail end of that experience, feeling much better about life than I was 4 years earlier. But to my left and right there, on the right of the photograph, that's actually my wife, now a palliative care physician who I met along with my classmate on the right there, competing for various graduate school scholarships at the behest of the West Point dean. So I had a bit of a circuitous, goofy path to medical school, where shortly after graduating the academy, I had the opportunity to study public health for a while. HIV testing policy in sub-Saharan Africa, of all things, not exactly a topic that I'm reaching for with regularity today, but it just speaks to the interesting experiences that the military often offers those of us in uniform. They have a very vested interest, we all do, in making sure that all of us have a very broad-based exposure to various experiences and education. And it's been one of the pieces of my military career for which I've been most grateful. After that, I HPSP for medical school, quickly determined that all that HIV testing policy stuff and infectious disease was not for me in a clinical context, and very quickly gravitated towards emergency medicine, as it seems you all have or are in the process of doing, which I think you'll be quite happy with that decision. There's a lot of natural overlap between what the military needs and emergency medicine as a specialty. So there's not real any dissonance there between your professional responsibility and your technical expertise. Trained at Brooke Army Medical Center, which we'll talk about later, but this photograph here is shortly after graduation from residency and overlooking the HKIA airport, where everybody knows this from the 2021 withdrawal, but I deployed there in 2016. Experienced my first combat casualty, lives saved, but also deaths during that experience, which was a very intense experience, but imbued me with a profound dedication to trying to give all of those in uniform the best possible chance to come home alive. Next slide, please. This is also from HKIA, the flags of the NATO partners who served with us. So I had the good fortune of being able to work with a multinational group of physicians, nurses, medics, and this is really a testament to the benefit of the post-World War II security architecture that we all benefit from most of our grandparents' generation. But very close bonds here with our multinational partners. Next slide, please. Shortly after that, I have what I like to joke was a midlife crisis, and decided if I'm going to spend a career in the military, I should probably get some more exposure to the operational side of things. And the Army gave me an offer I couldn't refuse by offering to PCS me to beautiful Colorado Springs. So this is a Armor Brigade combat team on Fort Carson, where I served as a medical advisor for a maneuver commander. And this is right about the time that COVID hit. So it was a very interesting experience. For the first time in my career, I'm in a position where I'm the only physician in the room. And it happens to be during a public health catastrophe. And so my charge was to try to leverage a military maneuver apparatus as a public health machine with mixed success. And some other time or place we can talk a little bit more about how that went. But just sort of speaks to the fact that we are the supporters of an organization whose real purpose is to close with and destroy the enemies of the United States. So it does require kind of a mind shift sometimes in how we approach our professional work. Next slide, please. But from there, I had the opportunity to move back into more of a medically focused space. So the Chief of Staff of the Army stood up several new forward resuscitative surgical detachments across the Army, one of which at Carson, and I had the opportunity to take command of that. Each of the services have similar small surgical elements. This is a picture of a chemical biologic protective shelter, or a vehicle which deploys these shelters on the back that deliver positive pressure in an attempt to establish a semi-sterile environment. But it just sort of, in a picture, gives you a glimpse of how these surgical teams can remain mobile on the battlefield, quickly establish, perform initial surgical interventions, and then keep moving. Next slide, please. That job had really impressed upon me the unique responsibilities that come with being a commander that, in my opinion, are no less solemn and important than those we all take as physicians. It inspired me to compete for an 05 command, and I was honored to get command of the 14th Field Hospital. This is the ceremony where the higher commander is passing me the colors there. So this just layered on an additional level of complexity in how do you master the myriad aspects of a hospital, including the ancillary services, operating room, ICU, pharmacy lab, etc. I was no longer able to just focus on my comfort area in the emergency department. Next slide, please. But this somewhat grainy photograph is from my 10-month deployment in that role as the Role 3 commander in Iraq. Actually, during that deployment, we swapped places from Baghdad to Erbil with the Navy Expeditionary Medical Unit there. So it sounds like Dr. Clark is getting ready to relieve the folks that we swap places with, which just goes to show you that it's a very small military world, and you will inevitably encounter folks over and over again. And it also speaks to the joint nature of how military medical care is delivered in the deployed environment. We're an Army unit, but alongside us were Air Force and Navy medical units, all with the same responsibility of saving lives on the battlefield. Next slide, please. And so this finally brings me back to my current position as program director of the Brooke Army Medical Center emergency medicine residency, again, where I trained, and I just took that over about 5 months ago. And it is a true pleasure to be back. This is a facility that means a great deal to me, both because of the skills that I've gained here, but also, frankly, the medical care that my family has received in this hospital. My son was born in this hospital. And we really are proud of this facility, standing at the epicenter of military medicine in San Antonio. This hospital has been the basis for preparing physicians, nurses, medics to go downrange and save lives on the battlefield, stretching all the way back to 1879. Next slide, please. So Dr. Cox had said in his prompt that I could take some time in addition to sell my program, and that's what I'm going to shamelessly do for just the last couple of minutes here. But again, we are laser focused on a fundamental purpose of saving lives on the battlefield. And to get after that, we focus on taking care of our residents to make sure that they can take care of our patients. We craft them to be leaders. And we posture them to win or be successful in achieving any of their goals following graduation, with really the end state that any graduate's going to be able to achieve his or her full potential and excel in any setting where they end up moving, either in the military or thereafter. Next slide, please. These are some quick photographs from San Antonio. It's certainly a larger city, but I think sometimes people who have not been in person don't appreciate just how diverse it is culturally, as well as topographically, with hiking trails. And there's a lot of beauty here. And every year I've been here, I've fallen a little bit more in love with it. It's been a real pleasure to come back home. Next slide, please. Next, this is just some images from our residents. I like to think they work hard, they play hard, they have fun. It's a great culture, and we're very proud of it. Next slide, please. And this just speaks to the incredible volume and acuity that we have to offer in this facility. Within the DoD, it is certainly far and away the largest and most complex patient collection that you will see inside of a military treatment facility. And then at the bottom there, you can see the plethora of partners that we have, to include partners outside of Texas, where we have rotators go to Denver for toxicology, as well as a rotation down in Honduras for global health engagement, and kind of a whetting of the appetite of what deployed medicine can look like after graduation. Next slide, please. And then the last piece, and arguably the most important, because let's be honest, any ACGME certified residency is going to give you excellent training to prepare you to be an emergency physician. But we really strive to lean heavily into some of the things Dr. Snyder and Dr. Clark talked about, where we expose you to the military unique curriculum and ensure that during your residency, you get some understanding in tactical combat casualty care to a level of expertise where when you graduate, you'll be able to deliver that knowledge and understanding down to the lowest levels of the medical echelons that you're responsible for. Because the reality is, even as a brand new graduate, the Army, Air Force, Navy is going to immediately look at you as a senior leader, as an expert in your craft, and expect you to be able to percolate that knowledge all the way down, because you're not going to be there every single time there's a combat casualty that needs help. Next slide, please. All right. Lastly, there's my contact info, and I look forward to connecting with you all in the breakout rooms. Ryan, back over to you.
Thank you so much for a great talk, Lieutenant Colonel April. Really appreciate that. With that said, we will turn over to our final speaker for the first portion, and that is Lieutenant Colonel retired Tori McGowan. She's going to speak about her Air Force career and what she has done since retiring from the military.
My name's Tori McGowan. I am retired from the U.S. Air Force. My story starts technically on 26 June 1997. That was the day that I in processed at the Air Force Academy. Colonel April, I'm very sorry that you weren't able to get in, and I'm glad you got into your safety school. Not all of us can be Air Force. What can I say? This was the day that I graduated and took my commission in the Air Force. I was waitlisted for Oregon Health and Sciences, and my plan was to go to USUS, but I was lucky enough to be able to come off the wait list and go to school where my parents had gone to school. So that was a really cool opportunity to come back home. One thing that I want to point out is you'll notice the date here. Colonel April spoke about this, that he in processed in 2001 to West Point. I had already graduated and signed my medical school contract that I was going to be in until 2017 at a minimum. And then 9/11 happened. I joined a peacetime military, and I thought I was going to serve just like my instructors had served in a peacetime military. And the most that anyone had done was 6 weeks in Desert Storm. And my career was a very different career than what I thought I was going to have. So whatever you think your career is going to be, understand that it will be wildly different than what you think. 20 years is a long time and a lot changes. Next slide, please. I graduated from the Air Force Academy. I then did the HPSP program at Oregon Health and Sciences University. One of the ladies earlier spoke about civilian deferrals, and I believe it was Lieutenant Clark. The year that I was matching into residency, there were 0 deferred slots. And so you either trained in the military or you didn't train at all. So I was just really excited. Back then, also, there were only 2 military programs. It was Wright-Patterson or San Antonio. And so I was lucky enough to get selected to attend San Antonio at Wilford Hall and BAMC. So that's how old I am. I am Wilford Hall old. Yes, I did graduate from the best residency program, and allow me to date myself a little bit more. I believe, Colonel April, and you can correct me here, I believe that one of my residency classmates was the program director for the guy who is now the program director. So I am now 2 generations of program directors old at SOSHEC. So Ryan
That's
has been very
correct.
kind in introducing
Your classmate
me today.
was also my boss in Iraq. So you have a lot of classmates I've interfaced with.
Yeah. So it's a very small military, a very small group. So be a jerk to somebody at your own peril, because chances are really good you're going to deploy with them and it's going to be a really awkward 6 months. Play nice in the sandbox. Standing here with me, so one of my other residency classmates is Colonel Melissa Dooley. She is currently the Air Force Special Operations Command Surgeon General. So she's out there just absolutely killing it and doing amazing things. Next slide, please. This is where my career has taken me. I was lucky enough to go from San Antonio to Elmendorf, Alaska. Spent a couple of years up there. I deployed from there to Iraq. The military was kind enough to deploy me from Alaska to the desert in the Middle East and sent me with all of my cold weather gear, which they did not issue me when I got to Alaska, which I thought was weird. I then PCS from there down to Travis Air Force Base and spent the rest of my active duty career at Travis Air Force Base with a trip to Bagram, Afghanistan. Next, please. You can see the timeline there. 4 years. I have worn the uniform in a lot of different ways. So I spent 4 years as an Air Force Academy cadet, 4 years in the IRR as a reservist in medical school, 12 years active duty, and then 7+ years in the Oregon Air National Guard. So I have a lot of opportunities to wear the uniform in a lot of different ways. Next, please. So obviously I have lots of stories and I'm happy to tell them in the breakout sections, but what I was specifically asked to talk about was how I've managed to have a 27-year career in the military, plus let's not even talk about how long medicine, and really still enjoy it and still enjoy coming to work every day. I'm coming off a night shift today, so please excuse the bags under my eyes, but I still like it and I still want to go to work. I'm sure that you guys are hearing a lot about burnout. So burnout is a huge buzzword. And if you're not actually aware, there's a clinical diagnosis of burnout, and it has 3 components, and that's cynicism, emotional exhaustion, and depersonalization. So how do you avoid that? We talk a lot about it, but how do you avoid burnout? So what's the opposite of burnout? Next slide. The opposite of burnout is engagement. So remember that depersonalization, it's hard to depersonalize people when you're actively engaged with them. And the emotional exhaustion, you get filled up by other people who are interested and enthusiastic about what you are doing together as a group. Interestingly, there's a lot of talk about combat stress and PTSD when you're deployed, but there's actually not a lot of burnout because you're all doing the same thing and there's a great community there. This was my group in Bagram, standing underneath the American flag that you rolled under as you were coming into the Bagram Trauma Bay. Next, please. And so how do you get engaged? Organized medicine is one of the ways to do that. And there are a lot of debates on what's the best group to be involved with. I personally involved with ACEP, American College of Emergency Physicians. Last I saw, I think it's about 43,000 emergency physicians across the United States. AAEM is another excellent group, American Academy of Emergency Medicine, that is really dedicated to preserving autonomy for emergency physicians, as well as promoting democratic groups and the democratic practice of emergency medicine. Society of Academic Emergency Medicine, Special Operations Medical Association, Wilderness Medicine, Narrative Collaborative, whatever your passion is in medicine, somebody else out there enjoys it too. And if you can find that group, you will have a much more fulfilling career. Next, please. You're going to hear a lot of different opinions on which of those is better. The bottom line is find the group that you fit in with. There really isn't a better or worse or different. It's just where you belong, where you find that you belong. And ACEP was where I found that I belong. This is just various pictures of the people that I get to spend time with. I go to ACEP every single year. I have gone every year to Scientific Assembly. And almost every year to government services, except when government services schedules when I've already committed somewhere else or when I've been deployed. But that's 20 years of going to conferences and having that opportunity. Next, please. I want to also point out that ACEP has a chapter that is just for you, just for the military. The way that ACEP is organized is you have chapters that are, most of them are geographic based. So you have your state chapter, and the chapters are really the groups that do the advocacy and the networking and the feeding leadership into the college. And when you're in the military and you move every couple of years, it's hard, and especially if you're overseas, what chapter do you belong to? It's hard to figure out who do you belong with. And ACEP recognized that almost 50 years ago when we all started as a group, and they created the government services chapter so that you can have a chapter home that you don't have to change every time you move. And we actually advocate for the issues that face federal emergency physicians. So that's active duty, Guard and Reserve, VA, Indian Health Service, State Department, like CIA physicians are all, we represent those issues, which are slightly different than what, for example, Oregon's issues are, which is where I live now. Next, please. One of the most important things about ACEP and GSACEP is connection. So next, Bill. This particular picture here is the group of GSACEP leaders at ACEP one year that is just at our lunch. And in this picture alone, you will see 3 retired generals or current acting generals, 2 ACEP presidents, 2 council speakers. The gentleman in the middle on the left, it was the chief of emergency medicine for the VA for the national level. And then, of course, on the lower left is Bernie Carr, who was our executive director for GSACEP for about 30 years and basically built our chapter together. These are incredibly powerful people in this picture and have done a tremendous amount of good for our specialty as well as military emergency medicine. And you get to just sit and have lunch with them and have drinks with them, which is one of the best parts of ACEP and GSACEP. Next, please. The other thing that will help your career be interesting and fun is connecting outside of medicine. So this group of ladies is a group of women that are all physicians who ride horses and are also emergency medicine physicians. These are the ones that represent their various states, and you can see the states there in the pictures at ACEP Council. There are about 2,000 women that all connected on Facebook that are equestrians and ride horses. And about 100 of us get together every year in Tucson and pay lots of money to ride somebody else's horses and drink margaritas in the desert. The ability to make these connections and to make meaning beyond just medicine and have an opportunity to get to know other people and see that these are humans behind that person on the phone call. Women in this group serve as my stealth consultants. So when my urologist is giving me a question that I don't really know if I believe or not, or they are not answering my question, I reach out to my friend Felicia, who is actually at Walter Reed. So Felicia Balzano, she is a reconstructive urologist, and she gets the text at 2:00 in the morning, and she's able to answer me about whether or not I need to do something different for this patient. These are the types of connections that will make your career rich and fulfilling and a lot of fun. Next, please. When I left San Antonio, when I left residency, so you heard a lot of talk earlier about how cool residency is, and everybody wants you to get out and see all of the different things in medicine and see all the different niches that you can do, like dive medicine and global medicine. Here's the deal. When you graduate and you go to work, nobody's interested in broadening your horizons. They want you to work and work lots of shifts because that's what you're supposed to do. There are patients to be seen. And it is really easy to leave your residency and just disappear into a small hospital that doesn't have a lot of trauma, that doesn't have a lot of engagement, and never be seen again for your military career. That's a choice. It's not very much fun. And so one of the things that ACEP allowed me to do was to continue to develop leadership and skills and to develop as a leader, even though I was in a ER that it had 8 physicians staffed there. The ACEP Council is where the leaders of the chapters of ACEP come together, and we set policy for the upcoming year and what we think ACEP should advocate for and spend their time talking about. This is a couple of years ago when I was able to lead a reference committee at ACEP, and that was me standing up in front of about 600 people and giving someone the death glare because they were interrupting what I was doing. So apparently my face does not need any subtitles. You can tell exactly what I'm thinking. ACEP Board of Directors, we have several GS-ACEP members who have served as ACEP Board of Directors and ACEP presidents, including one who did that while on active duty. That was Linda Lawrence. You can also serve on national committees. So I just finished my time as the chair of the communications committee for ACEP. I'm also on the disaster committee and the education committee. So I have these opportunities to help shape ACEP policy and have that chance to engage, even though I'm at a small hospital that doesn't really have much political power. Next slide, please. The other thing that I get to do that is really cool is I started speaking through ACEP. And so every year I lecture at ACEP and I talk about mass casualty management and I talk about disaster medicine and I talk about human factors analysis. There is a very strong tendency if you leave your academic place and you go out into a community hospital, it is really easy to lose those connections. And most people aren't working in an academic center. Most people are in these smaller hospitals. And so those perspectives are important to be able to bring forward, because when you hear somebody lecturing about how wonderful it is at my level 1 trauma center, and I just have the neuro-ophthalmologist come down and consult on my patient, the nearest neuro-ophthalmologist to me is 3 hours away. So how do you manage that patient without those specialties in-house? And having that opportunity to talk about that is really powerful. I've traveled all over the country. People pay me to come speak to their attendees, and it's a really fun opportunity. Advocacy, I also have a chance to advocate for emergency medicine, both on the national and the state level, and that's all through ACEP and GS-ACEP. Next, please. This is me at the Capitol Rotunda. Sorry, that was a quick one. Capitol Rotunda, and had the opportunity to lobby Congress last year. Next, please. This is the Green Monster at Fenway Park. Getting the opportunity to do a back scenes tour at Fenway when we were in Boston last year. Again, just an opportunity to see a lot of the world that I never would have imagined was going to be available to me. Next, please. Next, please. Just some different pictures of all the different places that I've gone. I also had a chance to meet Elvis. I'm actually not that old. I was kidding. Next, please. I like to call this idea my stealth academic. So I'm not a researcher. I'm not an academician. I have never been at a residency teaching program, although I think I'm an associate professor with USIS because of the students that I've taught in our smaller hospitals over the years. Because of my connections through ASAP, I have had an opportunity. The newest edition of the Schultz Disaster Medicine textbook. I had an opportunity to write one of the chapters. I've written guidelines for wilderness medicine, many of those clinical practice guidelines for the DoD trauma system. All of my work has now been superseded because they've been updated so many times, but I had the opportunity to write to be on the committees that wrote those clinical practice guidelines. And those connections only came through GSASEP. Next, please. I am out of time, so I'm going to stop here. I'm happy to talk in the breakout sections about time in the Guard and Reserve and a little bit of what I had the opportunity to do there. And happy to see you in the breakout sections and take some questions.
Thank you so much for the engaging talk, Dr. McGowan, and also for featuring a horse in your background in a very, very fitting decision. With that, I'll turn it back over to Colonel Cox before we go to the breakout rooms.
Yeah, thank you. Big thank you to all the speakers. Some great stories, lots of great photos. You can see you can have a diverse career in military medicine. For the breakout rooms, for next month, we have internal medicine. So we've got a Navy immunologist, allergy immunologist, who's going to be talking about his research. Dr. Massey has had a roundabout tour and spent the last 5 years in Italy. And then Dr. Winslow is now a professor of medicine and pediatrics at Stanford. And has a storied history with plenty of deployments. But that'll be next month or December 1st. So please join us there. I'm really excited about our January military medical community, where we're going to feature plastics, physical med rehab, and dermatology. But for right now, I'd like to, the link is in the chat. It's also right there on the front, on the screen. Join us in one of the breakout rooms. You can talk to a physician recruiter from the Army, Navy, Air Force, HPSP. You can ask questions of USU students or the USU admissions committee. And then we also have the emergency medicine breakout rooms where you can talk to a program director or just link up a network. So thank you everyone for coming and hanging out. Go ahead and tap out and we'll see you guys in the breakout rooms.